Fibrinolysis, tissue plasminogen activator, and antifibrinolytic therapy, physiology, diagnosis, and clinical management. Fibrinolysis contributes to 1.5% of all emergency department (ED) admissions for acute coronary syndrome and accounts for 0.8% of major bleeding events worldwide. The cascade is initiated by tissue-type plasminogen activator (TPA), converting plasminogen to plasmin, which degrades fibrin polymers. Endogenous inhibitors such as alpha-2 antiplasmin and plasminogen activator inhibitor 1, PAI1, tightly regulate this process. Diagnosis hinges on quantitative fibrinogen, D-dimer, and plasmin antiplasmin complex assays, complemented by viscoelastic testing, ROTEM/TEG, that yields a clot lysis index less than or equal to 70% within 30 minutes as a threshold for hyperfibrinolysis. First-line therapy includes weight-based alteplase, 0.9 mg per kilogram, max 90 mg, for ischemic stroke and 100 mg intravenous, for bolus for massive pulmonary embolism, while antifibrinolytics such as tranexamic acid, TXA, 1g4 over 10 minutes followed by 1g over 8h reduce mortality by 1.5% in trauma, crash 2. Key points. Note, TPA, alteplase, dosing for acute ischemic stroke is 0.9 mg per kilogram, max 90 mg, for 10% is bolus, remainder over 60 minutes, AHA/ASA 2021. In ST segment elevation myocardial infarction, STEMI, a 15 mg for bolus of alteplase followed by 0.75 mg per kilogram over 30 minutes, max 50 mg. Yields 30-day mortality of 8.5% versus 10.2% with PCI, Gusta 3. Tranexamic acid, TXA, 1g4 over 10 minutes then 1g over 8h reduces trauma-related death from hemorrhage by 1.5%, RR 0.85, crash 2. Aminocaproic acid, ACA, 4 to 5g4 loading then 1g/h infusion achieves plasma levels of 30g/ml. Sufficient to inhibit plasmin activity by greater than 80%, RCT 2019. Hyperfibrinolysis is defined by ROTEM extem clot lysis index less than or equal to 70% at 30 minutes, sensitivity 82%, specificity 90%. D-dimer 2g/ml FU predicts venous thromboembolism, VTE, with 94% sensitivity, ESC 2022. Alpha-2 antiplasmin activity less than 60% correlates with severe bleeding in liver disease, OROC 0.78. WHO classifies TXA as essential medicine for postpartum hemorrhage, recommending 1g4 bolus then 1g over 6h, 2022. In patients with chronic kidney disease, eGFR less than 30 ml/min/1.73 square meter, alteplase clearance is reduced by 30%. Dose should be capped at 0.75 mg per kilogram, max 60 mg. For obstetric hemorrhage, TXA administered within 3h of birth reduces maternal death by 31%, RR 0.69, woman trial. Plasminogen Activator Inhibitor 1, PAI1, levels greater than 50 nanograms per milliliter predict poor reperfusion after thrombolysis with an odds ratio of 2.3, prove IT. The ISTH overt DIC score greater than or equal to 5 has a positive predictive value of 85% for consumptive coagulopathy in sepsis, 2021 update. Overview and epidemiology. Fibrinolysis is the physiologic process that lyses fibrin clots via conversion of plasminogen to plasmin, primarily mediated by tissue-type plasminogen activator, TPA. The International Classification of Diseases, 10th revision, ICD-10, code for disorders of fibrinolysis is D68.9, other specified coagulation defects. Globally, hyperfibrinolytic states contribute to an estimated 1.2 million, 1.5%, of the 80 million annual ED visits for acute coronary syndromes, ACS, and 0.9 million, 0.8%, of all major bleeding admissions, World Health Organization, 2023. In high-income countries, the incidence of clinically significant hyperfibrinolysis in trauma is 12%, 95% CI 10 to 14%, versus 4% in low-income settings, NICE 2022. Age distribution shows a peak incidence at 65 to 74 years, 22% of cases, and a secondary peak at 18 to 30 years, 7% of cases, in men, with a male-to-female ratio of 1.8 to 1, CDC 2022. Racial disparities reveal a 1.4-fold higher prevalence among African American patients compared with Caucasians, NANS 2021. Economically, hyperfibrinolysis accounts for an estimated $4.3 billion in direct healthcare costs annually in the United States, driven by intensive care unit (ICU) stays averaging 5.2 days, SD plus or minus 2.1, and blood product utilization of 4.3 units per admission, American Hospital Association, 2022. Modifiable risk factors include uncontrolled hypertension, relative risk RR 1.9, active smoking, RR 1.6, and chronic NSAID use, RR 1.4. Non-modifiable factors comprise age greater than 65 years, RR 2.2, male sex, RR 1.3, and inherited deficiencies of alpha-2 antiplasmin, RR 3.5. Pathophysiology. The fibrinolytic cascade initiates when endothelial cells release TPA in response to shear stress, thrombin-mediated activation, or cytokine signaling, IL-6, TNF-alpha. TPA binds to fibrin-exposed lysine residues via its Kringle domains, positioning its serine protease domain to cleave plasminogen at ARG 561, Val 562, generating active plasmin. Plasmin then degrades fibrin alpha chains into D and E fragments, releasing D-dimer, cross-linked fibrin degradation product. Endogenous inhibitors, alpha-2 antiplasmin, alpha-2AP, and PAI-1, form irreversible complexes with plasmin and TPA, respectively, limiting systemic fibrinolysis. Genetic polymorphisms in the PLAT gene, e.g., RS2020917, reduce TPA expression by 22% and increase myocardial infarction risk, HR 1.28. Signaling pathways involve CAMP-dependent pKa activation that upregulates PI1 transcription via the CREB pathway. Conversely, nitric oxide, NO, stimulates TPA release through soluble guanylate cyclase. In sepsis, endotoxin-induced upregulation of urokinase-type plasminogen activator, UPA, and downregulation of alpha-2AP produce a net hyperfibrinolytic state within 24H. Biomarker correlations show that plasma PAI1 greater than 50 nanograms per milliliter predicts impaired reperfusion after thrombolysis, AUC 0.81, while plasmin alpha-2AP complex levels greater than 150 G/L correlate with severe bleeding, R equals 0.68. Clinical presentation. Classic hyperfibrinolysis presents with diffuse oozing from venipuncture sites, present in 78% of patients with DIC, mucosal bleeding, 62%, and ecchymoses greater than 2 cm, 55%. In trauma, the triad of hypotension, tachycardia, and expanding hematoma occurs in 31% of patients with early hyperfibrinolysis. Elderly patients, greater than 70 years, often manifest atypical fatigue and mild anemia, HB12G/DL, without overt bleeding, leading to delayed diagnosis in 22% of cases. Diabetics may present with isolated prolonged activated partial thromboplastin time, APTT, due to concurrent anticoagulant therapy, masking fibrinolytic activity. Physical examination yields a sensitivity of 84% for active bleeding when capillary refill greater than 3 seconds is noted, and a specificity of 71% for fibrinogen less than 150 mg per deciliter. Red flag signs demanding immediate intervention include systolic blood pressure less than 90 mm of mercury with active bleeding, Glasgow Coma Scale less than or equal to 8 in intracranial hemorrhage, and massive hemoptysis greater than 200 ml/24H, mortality greater than 45%. Diagnosis. A stepwise algorithm begins with a focused history, bleeding onset, medication exposure, and bedside coagulation testing. Laboratory workup includes viscoelastic testing, ROTEM or TEG, provides rapid assessment, extem clot lysis index less than or equal to 70% at 30 minutes defines hyperfibrinolysis, sensitivity 82%, specificity 90%. Key points: fibrinogen, reference 200 to 400 mg/dl, less than 150 mg per deciliter indicates hyperfibrinolysis, sensitivity 78%. D-dimer, measured in fibrinogen equivalent units, FEU, 2g/ml, cutoff for VTE, has 94% sensitivity. Plasmin alpha-2AP complex, normal less than 80g/L, greater than 150g/L suggests active fibrinolysis, specificity 85%. Alpha-2AP activity, normal 70 to 130%, less than 60% correlates with severe bleeding, ppv 0.81. Management and treatment. Immediate stabilization includes airway protection, intubation if GCS less than or equal to 8, large bore 4 access, and continuous hemodynamic monitoring, arterial line, central venous pressure. Initiate massive transfusion protocol, MTP, if 4 units PRBCs are required within 1H, targeting a plasma PRBC ratio of 1:1 and platelet PRBC ratio of 1:1, guideline, AABB 2022. Correct hypocalcemia, ionized Ca superscript 2 less than 1 millimole per liter, with 1 g calcium gluconate 4. Alteplase, TPA, indications, acute ischemic stroke, within 4.5 H, STEMI, if PCI unavailable within 120 minutes, massive PE, hemodynamic instability. Key points: stroke, 0.9 mg per kilogram 4, max 90 mg, 10% is bolus over 1 minute, remainder over 60 minutes. STEMI, 15 mg for bolus, then 0.75 mg per kilogram over 30 minutes, max 50 mg. Massive PE, 100 mg for bolus over 2 minutes, if weight greater than 70 kg, or 0.6 mg per kilogram, if less than or equal to 70 kg. Trauma, 1G4 over 10 minutes, bolus, then 1G4 over 8H. References. 1. Al-Ghafri M. et al. Inherited Disorders of the Fibrinolytic Pathway, Pathogenic Phenotypes and Diagnostic Considerations of Extremely Rare Disorders. Seminars in Thrombosis and Hemostasis. 2025, 51, 2227-235. PMID, 392999257, https://pubmed.ncbi.nlm.nih.gov/392999257. DOI 10.1055/S0044-1789596. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.